Well, welcome everyone to the HSC Office for Diversity, Equity, Inclusion, Disability Awareness Month event today. I'm Dr. JP Sanchez. I serve as the Executive Associate Vice President in the HSC office. On behalf of all of us at the HSC Office of DEI and Vice President Dr. Romero Leggett, we'd like to thank you for making time to join us. For those who are unable to join us today, this presentation will be recorded and posted on the HSC Celebrations webpage. Before we begin, I just want to go over a few housekeeping items. Please place your questions in the chat box at the bottom of your screen. We will try and answer as many as we can towards the end of the presentation. Please also take a moment to complete the pre-assessment in the chat box. This will help us understand your interests and reflections during the month. And at the end of the presentation, Dr. Swan will be sending another link for the post-assessment workshop. I'm grateful and excited that we have one of our own, Dr. Rebecca Dutton, who serves as the chair of the Department of Physical Medicine and Rehab at the University of New Mexico School of Medicine. This is a new appointment that she received this past year, so congratulations again, Dr. Dutton. And she'll be presenting today on disability in rural New Mexico, considerations to drive change. Thank you again so much, Chairperson Dutton.
Thank you, and thank you so much for having me today. I'm really excited for the opportunity to speak a little bit more about disability as it relates to our community here in the state of New Mexico. Before we get started, I have no relevant financial or non-financial disclosures. I have three primary objectives for this session today. By the end of the session, learners should be able to recognize patterns of disability as well as the association between disability and rural settings in New Mexico, describe common features of rural communities and rehabilitation medicine that can challenge the provision of rehabilitative care for individuals with disability in rural settings, and to be able to discuss opportunities to promote function and quality of life for individuals with disability living in some of the more rural areas of New Mexico. So with that, let's begin by talking a little bit more about disability as it relates to our rural landscape here in the state. New Mexico is the 5th largest state by landmass, but it is also the 6th least densely populated state in the United States, with a population density of about 17 residents per square mile. There are only 4 cities in the entire state with a population greater than 50,000. These include Albuquerque, Las Cruces, Rio Rancho, and Santa Fe. So it follows that a minority of counties would be considered metropolitan or small metropolitan counties, with the majority being more rural in nature. And importantly, 32 of the 33 counties in our state are considered health professional shortage areas, meaning that there is an insufficient number of healthcare providers in those counties to meet the needs of the individuals living there. With regards to disability, these statistics vary a little bit depending on how one defines disability. However, this comes from the CDC and estimates that about 1 in 4 individuals or adults in New Mexico are living with a disability. The most common forms of disability in our state include impairments in mobility and cognition. And another way that we will frequently measure or quantify disability is through disability adjusted life years. And disability adjusted life years mean the total number of years of life lost due to premature mortality and the number of years lived with disability. So a higher number of DALYs or disability adjusted life years indicates a higher burden of disease and disability. And what we can see in this map here is that New Mexico has overall a higher or a disproportionate burden of disability when compared against the rest of the nation. And importantly, if we were to blow this map up further, what we see is that over the last 2 decades, this gap actually appears to be widening. So if we come back now to the map that we saw before, and how disability relates to some of these counties and communities. First off, what you can see is that there are two relatively large clusters of rural counties, one in the Midwestern portion of the state and the other in the northeastern portion of the state. And these areas seem to shoulder the greatest burden of disability, with higher rates of disability noted very clearly in these two areas. And the lowest disability rates appear to be mainly in the counties surrounding the 5 largest urban areas. And so then the question becomes, why is this? And this is probably multifactorial in nature. For one, we know that individuals living in rural areas tend to be older and tend to have higher comorbidities. So we know that there are lifestyle factors and living conditions and other things that may be predisposing to disability in the first place in these more rural communities. And then, as we'll see a little bit later in the talk, there is probably also less access to quality care focused on the mitigation of disability and optimization of function in these rural communities. And so really, when we think about how to approach this problem or this challenge, we need to be thinking about both the preventative side of things as well as the management side of things. I will be focusing for the rest of the talk today more on management and how we optimize care for individuals living with disability in rural areas, but I cannot overemphasize the importance of the preventative side of this puzzle as well. So I represent a field known as physical medicine and rehabilitation, or physiatry. And this is a subspecialty or a medical specialty that emphasizes the diagnosis, treatment, and rehabilitation of people disabled by disease, disorder, or injury. And the emphasis of this specialty is really on functional restoration, independence, and quality of life. So again, overall management of individuals living with disability. And if we look at the number of physical medicine and rehabilitation specialists in the state of New Mexico, there are 41 currently practicing board certified physiatrists in the state. And we do rank in the bottom 4 states for the number of physiatrists per capita. And you can see in this map here that the predominance of PM&R physicians are localized in Albuquerque. This map becomes even more bleak if we isolate the number of physiatrists who are practicing in areas related to what we call the rehabilitation care continuum, So this refers to specialists focused on specific disabilities such as brain injury, spinal cord injury, amputation, and neuromuscular conditions. And so we see that this geographic gap to access becomes much greater for some of these individuals with these specific disabilities. And so the question really becomes, how do we mobilize high quality rehabilitation care to these more remote areas of the state when our providers are so kind of concentrated around Albuquerque? And really, to answer this question, we need to look at the rather complex interplay between specific characteristics of rural communities in general, and then some of the fundamental principles of rehabilitation medicine and how these relate to individuals living with disability in rural areas. So we'll begin by reflecting a bit further on some common characteristics that we see within rural communities. The first being that rural communities often have limited access or limited availability of health services. It is typical to see more significant financial barriers for individuals living in rural communities. These individuals tend to have a lower income, there tend to be higher rates of poverty, and they are more likely to be un- or underinsured. There are transportation barriers, so there can be environmental hurdles based on where a person lives, the quality of the roads. Sometimes there can be, environmental hurdles such as major mountain passes or things that need to be crossed to get to more urban centers. There's a cost, of course, to transportation, and then generally there's just less access to transportation. And then finally, technology barriers. So overall, less access to computing services and or reliable internet in these more rural settings. And each of these fundamental barriers can be exaggerated for individuals living with disability. So if we look first at the financial side of things, individuals with disability tend to face greater cost-related barriers to care. This was one study looking at a sample of non-elderly, meaning working-aged individuals with disability, and they found that the vast majority, 70% of those surveyed in their sample, had an annual income less than $24,000 per year. This is obviously compared to US non-elderly adults without disability. And again, you can see that there's a tremendous gap in terms of salary between the two. Not surprisingly, a very low percentage of these individuals with disability were employed, again, compared to what we would expect across a non-disabled population in the US of 74%. Also of note, while individuals with disability are more likely, to be insured, those who are uninsured seem to face larger barriers to care. So we see here that in this study, those who were uninsured and had a disability were much less likely to get necessary medical care and less likely to get necessary medications when compared to those who were uninsured and living without a disability. Next, if we turn our attention to transportation, this is a study looking at the various modes of transportation utilized by a population of individuals with disability. And we can see a broad range of transportation options, often though reliant on someone other than themselves to provide transportation. And notably, many of these methods of transportation are not particularly accessible in rural settings. And so we can see that individuals become increasingly reliant on either autonomous driving or friends and family to be able to access care outside of their community. And the challenges extend beyond just the availability of transportation, but in addition, there are concerns related to accessibility. So many vehicles can be challenging when it comes to making transfers, getting in and out of the car. There may not be adequate access or storage for durable medical equipment, such as wheelchairs. And then there can be a lack of access to handicap spaces. When autonomous driving is considered, there are certainly concerns related to safety. For example, if an individual has limited dexterity or impaired reflexes. And we know that there is a cost that comes with modifying vehicles. And so another potential barrier to accessing reliable and safe transportation. We see somewhat similar patterns when we look at technology barriers for individuals living with disability. This was a study looking at individuals who had suffered a stroke and their ability to utilize information and communication technology devices. And what we see is that beyond just access to the devices themselves and or reliable internet, cognitive impairments, speech deficits, impaired vision, just reduced cognitive abilities in general, limited utilization of information and communication technology. Their motor and sensory impairments were problematic, combined with potentially the physical design of the device, which made those devices very difficult to use. And we've seen similar patterns for other forms of disability as well, aging populations, spinal cord injury, brain injury, and so on. So this is all to say that individuals with disability living in rural settings face disproportionate barriers to healthcare access, and that we really need to be paying attention to strategies that enhance access, particularly because this population of individuals with disability tend to have more significant and/or frequent healthcare needs. The second aspect or feature of rural communities that I think is important to highlight is that while separate or distinct rural communities can often demonstrate significant diversity in their culture and values within a given community, we often see a shared set of culture and values. And this can affect or influence the way in which individuals in that community are interfacing with healthcare and the healthcare system. This can impact how illness, disease, disability is perceived, when and from whom healthcare is sought, attitudes toward and acceptance of healthcare providers, the way in which informed consent is received, and decisions regarding medical treatment. And so we see this if we look, for example, at indigenous communities and specifically their belief systems around disability. Disability is actually a concept that really does not exist for many indigenous communities. In fact, they often do not have a word to define the term. And frequently will embrace and celebrate disability. It is viewed as a natural part of being and reflecting what was intended for that individual by his or her creator. And individuals then are really valued as respected members of their society and recognized for the contributions that they are able to make to society rather than their impairments. So again, this concept of disability doesn't often translate to these native languages. This is a study in which the authors conducted semi-structured interviews of 18 indigenous persons living across 3 different countries. And they found fairly consistently that the term disability was really perceived as Western or doctor's language that was placing oftentimes inappropriately limitations on the individual's abilities. And then in fact, these individuals did not frequently consider themselves disabled, and that they were in fact able to do many things and contribute in many ways to their family and their communities. And this is a quote that I especially like. It says, "I don't identify myself as disabled. I find that word a negative, disgusting, deficit word. I don't know why anybody would want to diss my ability. It's that simple." Bringing this a little bit closer to home then and looking at the Navajo Nation, which certainly reflects one of the largest native populations that we see in the state of New Mexico. This study was conducted through interviews of families of 34 individuals who were experiencing severe impairment in the Navajo Nation. And they identified 2 major themes, one related to the concept of wellness, sickness, and cure, and the other related to the perception of disability. Firstly, illness in the Navajo culture is really often regarded as just a symptom of disharmony due to an external cause. And so treatment cannot be complete until that external cause has been addressed, although once it has, cure can really be achieved. So one can be cured even though the physical manifestations of their disease or disability may persist. With regards to perceptions around disability, much like we saw previously in the Navajo Nation, individuals are defined by their unique traits and respected for the contributions that they are able to make to the community. So they are often granted increasing responsibility so far as their abilities allow, and any skills that they are able to contribute are viewed as a value to the family and or the community's welfare. And importantly, we need to understand the impact that can be had when we fail to recognize the kind of social beliefs around disability. So in the same paper, they reference time back in the mid-1900s when individuals with disability living in on native reservations were actually being forcefully removed from their family and placed in institutions off of the reservation, often against the desire of the family because of an external perception that there was an inability to care for these individuals. And so consequently, families, native families at that time were actually starting to hide their loved ones with disabilities for fear that they would be taken from them. And so again, it is really critical to have a fundamental understanding of the belief system surrounding disability so as not to have such untoward consequences. Ignorance or dismissal regarding the perception of disability is a form of cultural discrimination, and the provision of inclusive care in rural settings and otherwise necessitates a fundamental understanding of a community's core beliefs and values. So this is all to say that we need to be focusing on providing accessible and culturally competent care in order to optimize outcomes for individuals living with disability in rural areas. Next, we will turn our attention to some of the fundamental principles of rehabilitation medicine. First and foremost, in the field of rehabilitation, care is provided not simply between a single provider and the patient and or his or her family and caregivers, but rather comes from an entire team of specialists really facilitating care for that individual and their caregivers. And we have found that this team-based model has been essential in optimizing patient outcomes. So it's been shown that close collaboration among providers with distinct skills can facilitate the setting of goals and selection of appropriate treatment options, as well as rapid information transfer, intervention, and expedited care. And in turn, it will improve functional outcomes and better survival. And this has particularly been shown in the literature for populations of stroke, traumatic brain injury, pulmonary rehabilitation, mental health, as well as chronic musculoskeletal and low back pain. And so this is all to say that rehabilitation medicine is really grounded in this interdisciplinary model whereby multiple disciplines work together towards integrated goals with agreed and shared strategies. And there's association between the disciplines with some overlap, but these are largely kind of distinct disciplines. Unfortunately, the provision of an interdisciplinary care model in rural settings can be challenged. This was a study in 2022, which identified several barriers, including insufficient human task force, lack of understanding and confidence among health professionals in rural settings, and limited knowledge of available resources. I will note that there were some facilitators identified as well, including smaller team size, a direct connection to the community, and flexible and an open outlook. So this begs the question, if we are looking to maintain a team-based model in a more rural or remote setting, do we need to think about perhaps more of a transdisciplinary model in which we are able to extend traditional roles for the team to members that allow flexibility of approach and expansion of skills, so as to sort of preserve resources in a sense. And this really requires additional exploration to understand further, but suffice it to say that the preservation of the rehabilitation team in rural settings is truly essential to providing effective and appropriately comprehensive rehabilitation care. And again, the exact model in which we do this really requires further investigation. Secondly, rehabilitation medicine transpires along a continuum. So that is, an individual with disability looks different 1 week after their disability than they look 1 month, then 1 year, then 10 years. And so the rehabilitation services really evolve over time in order to meet the needs of individuals at differing stages of injury or illness. And this often also occurs across a variety of settings. We will focus here first on the post-acute care setting, that is care that is immediately following an acute hospitalization for illness or injury. And post-acute care tends to occur in three primary locations: acute inpatient rehabilitation facilities, skilled nursing facilities, and then home health services, depending to an extent on an individual's disability, their comorbidities, and their rehabilitation needs. And what we can see in the literature is that there seems to be a fairly clear association between the utilization of post-acute care and what setting that's happening in, and the availability of said post-acute care settings. And so this was a study in 2005, which demonstrated first and foremost that patients living in rural settings are going to be geographically more separated from inpatient rehabilitation facilities. Inpatient rehabilitation facilities tend to have a slightly higher complexity and intensity of the care that they're offering than some of the other settings that I mentioned. And so what we can see here, MSA being a more metropolitan environment, and you can see this is across three different diagnoses who were admitted subsequently to various acute care settings, post-acute care settings. And you can see that in these metropolitan areas, individuals lived much more closely to an inpatient rehabilitation facility than their more rural counterparts. So we can see that even at the farthest distance, individuals in metro areas were no more than about 20 miles away from the nearest inpatient rehabilitation facility, as opposed to individuals in rural settings who were 75 to 80 miles away from an inpatient rehabilitation facility. And I would say that here in New Mexico, this geographic distance is actually much greater for many individuals living in some of the more remote areas of the state. And then the authors went on to demonstrate that the relative volume of inpatient rehabilitation facilities in a specific geographic area would actually predict use of the inpatient rehabilitation facility. So what we can see here is that individuals who had essentially a higher relative inpatient rehabilitation volume, much more likely, that regardless of their diagnosis, to be admitted to an inpatient rehabilitation facility than those who had a lower inpatient rehabilitation and higher skilled nursing facility volume. So anywhere from 8 to 13% likelihood if you were living in a low IRF volume location. And this was demonstrated in a subsequent study. What we can see here, again, very similarly, is that individuals living in more urban communities are more likely to be discharged to an inpatient rehabilitation service and or with home health agency services than their rural counterparts. And if we look at skilled nursing facilities, individuals living in more rural areas much more likely to be discharged to a skilled nursing facility than their urban counterparts. And in this study, what they also found was that after discharge from an institutional post-acute care setting, either inpatient rehabilitation facility or skilled nursing facility, patients living in rural areas were less likely to receive follow-up home health services, suggesting that this reduction in access persists along the continuum of rehabilitation. And this makes some sense in that a lot of these services that we're talking about, particularly inpatient rehabilitation, to an extent home health services, probably come at a higher cost. And these rural communities are going to have more limited resources to be able to provide this level of subspecialized care. However, it has been shown that appropriate access to and utilization of this rehabilitation care continuum is associated with better outcomes for individuals living with disability. And so this really means that we need to reflect on not just the location, but exactly what is happening in said locations or said settings when it comes to rehabilitation, how we are providing care in those settings in order to hopefully optimize outcomes for individuals with disability in more rural areas. So to summarize, it is important to develop systems that address the full continuum of rehabilitation care across all stages of injury and recovery in rural settings to maximize patient outcomes. And again, the best way in which we do this requires further investigation, but this is something that certainly we need to be looking at closer. So in addition to focusing on optimizing accessible and culturally competent care, we need to ensure that our care is fundamentally team-based and continuous, again, along that rehabilitation spectrum. And so I will leave here with a closing thought and, hopefully open things up for some discussion as well. This notion of centralization of medicine, in which a lot of subspecialty care is concentrated in more urban centers, is not novel. This is not unique to the state of New Mexico. And in many ways, the argument has been made that this model makes sense in terms of, again, maximizing the utilization of care. However, as you can see, it presents certain challenges, particularly for individuals living with disability in rural settings. We are here in the center of the state, and I think that we really need to be reflecting on how we can come together and really unite, considering accessibility, considering culturally competent care, considering team-based care, and considering care that occurs along a continuum or a spectrum for individuals with disability in order to really reach these more rural parts of our state and, again, improve the lives of those living with disability in these areas. Thank you.
Thank you so much, Dr. Dudden, for that excellent presentation and really opening our eyes to the state of physical medicine and rehab provision of care across New Mexico. A couple of things that came to mind that I wanted to get your thoughts on. One is the modality of telehealth. In what ways has telehealth been incorporated into the care of rehab medicine? And is there a benefit of incorporating telehealth for rural communities in the provision of rehab care?
Yeah, it's an excellent question, and something that we've looked at a little bit within our group, and certainly in the future, maybe next year, I'd be happy to provide sort of a part 2 or a follow-up to this. As I alluded to in the introduction, one of the challenges with telehealth can be just access to reliable internet, reliable information and communication services, and then an ability to utilize those services if you're somebody that's living with a disability or an impairment that again limits that use. So it is important, I think, when implementing telehealth strategies to really take that into account and look at the community with which one is working. Is this something that is going to be realistic and accessible? It absolutely has been implemented and studied in various populations. And again, I think when done mindfully, accounting for some of the barriers mentioned, it can certainly be a valuable tool. Where I came from, we worked on developing a fairly robust telehealth model for individuals living with spinal cord injuries that proved to be very successful. That kind of parlays also into Project ECHO. And this has been looked at for some populations of individuals with disability. Particularly, I'm most familiar with literature looking at the Project ECHO model in individuals with kind of chronic pain and disability related to pain. And interestingly, there's been somewhat varied results in the literature with that model. And the thought is that to an extent, there's a lot of buy-in that is necessary on the part of the provider living in the more rural community to kind of be part of the Project Echo sessions. And so, that is a barrier and a challenge, but it certainly is a model that needs to be, I think, explored further. And again, across people of other disability types as well.
Thank you for that. Also, since we exist within a health sciences center with a physician assistant program, with PT and OT, nursing, pharmacy, is there an exploration of how to support some of these individuals with disabilities through coordination with PT, OT, PA? What are the possibilities that have been explored, or what do you hope that we can explore moving forward with those other health professionals?
Yeah, that's a fantastic question, and I think that is the goal, right? Is because we have this robust group of really brilliant minds, again, with the School of Physical Therapy, the School of Occupational Therapy, School of Nursing, School of Medicine, bringing these groups together to really unpack ways that we can reach these communities better. I think historically, unfortunately, and this happens in a lot of academic settings, we end up kind of functioning in these silos, and we really need to come together as a team and as a group to think about how we can be mobilizing our expertise to improve the lives of people living with disabilities in rural communities. I don't have the answer, but I'm hoping that this kind of inspires some discussion around that for the future, because I really think, unfortunately, there in no part of the country right now is there a really great model for how to do this, right? And I think that this gap, if you will, between disability and rural settings, is commonplace, and we really need to be looking at a better model for delivery of care for this population. And I think we can be leaders in that.
Well, so, and I think you've already been leading this effort, so I'm excited to see what emerges next from the department and from the Health Sciences Center. So any other questions or thoughts from those on the call? As mentioned, Dr. Swan has put the post-assessment survey in the chat box. Any other questions or comments? Well, I just want to say thank you again, Dr. Dudden, Chairperson Dudden, for participating and making Disability Awareness Month so meaningful for our community. With that, I want to thank everyone for joining, and this concludes our session today. Take care, everyone.
Thank you.